All attendees are in listen-only mode.
All right, hello everyone and welcome to today's webinar, 2017 ASCO Recap, the latest in colorectal cancer research. I'm Sharon Worrell with Fight Colorectal Cancer, and before we get started, I want to thank the rest of the Fight CRC team, Michael Sola and the communications team for all your help getting the webinar up and underway. And of course, we're super excited to have Dr. Dustin Deming from the University of Wisconsin joining us today. After the webinar, you can review the recording at fightcrc.org/webinars. Also, after the webinar, you will get an email with links to the material and also to a survey. If you fill that survey out, we will send you an I Heart Booty bracelet as a thank you. During the webinar, you can ask questions using the panel on the right side of your screen. And we will have time for Q&A at the end of the session. Also, follow us along on Twitter using the hashtag CRCwebinar to stay up to date. Fight Colorectal Cancer has a comprehensive library of resources for patients, survivors, and others touched by colorectal cancer. Your Guide in the Fight was updated in January 2017 and is a detailed 3-part book discussing everything from dealing with a diagnosis to treatment decision-making and more for stage 3 and 4 CRC patients. The late-stage MSS CRC Trial Finder is a one-stop place to find and learn more about high-impact trials for colorectal cancer patients. The current data are limited to microsatellite stable, MSS, and stage 4 CRC patients. The list of trials curated on the Finder are sourced from the clinicaltrials.gov website, and to learn more, you can visit trialfinder.fightcrc.org. And a quick note that the information and services provided by Fight CRC are for general informational purposes only and are not intended to be a substitute for professional medical advice, diagnoses, or treatment. If you are ill or think that you may be ill, please see your doctor immediately, and in an emergency, call 911 or go to the nearest emergency room. Fight CRC never recommends or endorses any specific physicians, products, or treatments for any condition. And finally, we're so happy to have Dr. Deming with us today to talk about ASCO. Dr. Deming is a gastrointestinal oncologist and colorectal cancer lab researcher at the University of Wisconsin Carbone Cancer Center. He has a focus in the treatment of colon, rectal, and anal cancers, and at the age of 31 was diagnosed with stage 3 rectal cancer. As both practitioner, researcher, and a patient, he knows firsthand what the cancer journey is like and aims that his research changes the way in which we treat GI cancers to a more personalized approach. So thank you, Dusty, for being here today. I'm going to go ahead and hand the controllers over to you for the presentation.
Great, and thank you for that introduction. So today we're going to talk about some of the highlights, at least in my opinion, from this year's ASCO, specifically talking about things that are exciting in the world of colorectal cancer. Today we're going to talk about, in the metastatic setting, some advances in immunotherapies. We're going to talk about also in the metastatic setting some advances in precision medicine strategies. Regarding immunotherapies in that setting, what we're talking about are drugs that actually help kind of harness a patient's own immune system to fight the cancer, whereas precision medicine strategies are strategies in which we try to figure out what's wrong with a particular cancer, what makes that cancer cell a cancer cell, and try to take advantage of those findings to develop therapies for individual subtypes of colon cancer. Following that, we'll talk about advances in adjuvant chemotherapy. There's a lot of discussion about whether or not patients should be now treated with 3 versus 6 months of chemotherapy. And then we'll talk about some new data in the setting of survivorship. So let's get started. For metastatic cancer, in the advances in immunotherapy, we're going to talk about 3 topics. One is looking at a new immunotherapy combination for mismatch repair deficient or MSI high colorectal cancers. We're going to talk about a new immune therapy, CEA TCB bispecific antibody, which has shown some exciting preliminary results. And then we're going to talk about a new biomarker that I'm very hopeful will help identify patients with microsatellite stable colon cancer who might benefit from immune therapies. The first study to talk about is a combination of Nivolumab and Ipilimumab. These are 2 immuno-oncology or immunotherapy drugs, and in the Checkmate 142 study, they looked at the combination of these 2 drugs in patients who have mismatch repair deficient or MSI high cancers. As many I'm sure remember, this particular type of colorectal cancer represents about 3 to 4% of all metastatic colon cancer. And these particular types of colon cancer are very unique in that they can have hundreds or thousands of mutations in the cancer cell as opposed to much less than that in a typical microsatellite stable colorectal cancer cell. When there's that number of mutations in a cancer cell, those cancer cells end up looking a lot more abnormal to the immune system. And so they're easier for the immune system to detect as abnormal. And there has been some exciting advancements looking at immune therapies in that setting. Previously, only single agent therapies had really been investigated. So 1 immune therapy drug at a time. And that is recently, this has now been approved. So pembrolizumab, which is an anti-PD-1 drug, Keytruda is the other name for it, is now approved for MSI high colorectal cancer and actually all cancers that are MSI high or mismatch repair deficient. And so this study was looking at, would there be additional benefit to adding another drug, another immuno-oncology drug, to a very similar drug to pembrolizumab called Nivolumab. And what was found is in the combination of these 2 drugs for, again, patients with mismatch repair deficient or MSI high cancers, there was a profound response to this therapy. And so when you look at the graph that I'm showing here, all of these blue lines that are pointing down from 0, those are all patients for which their cancer shrunk on this therapy. And so what you can see is the vast majority of patients are having either stable disease or responding to therapy. So the partial response rate, so that's the number of patients who've had at least a 25% response to their treatment, 30% response to their treatment, those are 44% of patients, which is, 52%, total number of 44 patients, which was really exciting and much better than single agent immunotherapy. The other exciting thing here is that this spider plot, you can see all these lines are when the patient started therapy and then how their cancer responded, but then also how long it responded. And so you can see many of these patients are out beyond a year on this therapy, still doing very well. The other concern, or one of the concerns when you're adding an additional drug for patients is, does that mean additional side effects? And previously, the same drug combination has been studied for melanoma and some other disease types. Historically, this combination had been used at much higher doses. In this study, they are looking at lower doses, and only about 1 in 10 patients had to stop the treatment because of side effects that they weren't able to tolerate. So that was really exciting to see that patients were able to tolerate this lower dose regimen and potentially had great benefit from it. Before we move on, the big question is, well, now should all patients with MSI high or mismatch repair deficient cancers go on this doublet regimen? So the big question relates to this is that, well, people do pretty well with the single agent immune therapy regimen, and so it may not be necessary for many patients to go to the double regimen, but I'm hopeful that maybe this doublet regimen could be a way to enhance the response for patients who aren't responding as well to the single agent therapy. So hopefully this double immunotherapy regimen can help those patients who don't respond very well to the single agent first. The next study looks at a new therapy. This is a monoclonal antibody developed by Genentech that is exciting in that it binds two cells and brings them together. So there are two arms that bind actually to CEA. Many of you will know the name CEA from the tumor marker that we follow in colorectal cancer. So this antibody will bind onto the colorectal cancer cells because of the CEA, and also has a portion that will bind to the T cells or immune cells, bringing the cancer cell and the immune cells together. And what was shown is that this drug is fairly well tolerated, either as a single agent or in combination with another immunotherapy drug, an anti-PD-L1 drug, atezolizumab. The most common side effects were fever, infusion reactions, and diarrhea, but in general, those were fairly mild side effects for these patients, and overall, the side effect profile of the single agent or doublet regimen seemed pretty good. And then what they found was when we looked at patients with escalating doses of these drugs in the combination, especially when you got over a dose of 80 milligrams, many of the patients had either deep stable disease or responded to this therapy. And so this is a new therapy specifically in the setting of microsatellite stable colon cancer. So the other study was microsatellite unstable or MSI high cancers. Most of the patients on this study actually had microsatellite stable colon cancer. And so we're excited that this could be a new immune therapy option for patients with microsatellite stable colon cancer, but many more studies are needed before this will be approved. So another point is those patients who did respond to this therapy, even though the data is still early, it looks like those patients are responding for a long time, meaning that these responses do appear durable, though more data is clearly needed with this regimen. Lastly, in the setting of immune therapies, I want to talk about a new biomarker. So there is exciting work done by Fotis Asimakopoulos, and I've actually collaborated with him as well, looking at something called VCAN. VCAN is a protein that is in the tumor microenvironment. So it is around the tumor cells within the cancer, and it actually inhibits the ability of immune cells to come into the cancer. Excitingly, what we recently found was that when VCAN is broken down, so VCAN is the VCAN, the red here is showing that it's present within the cancers. When it's broken down, so you can see that's less red here in this particular tumor, it generates a fragment, which is staining red in this panel, called versicine. And this versicine is actually stimulatory to the immune system. So if you look at patients in whose cancer is low for versican, the immunoregulatory version, and high for versicine, the immunostimulatory version, what we see is that the CD8 T cell count that infiltrates those tumors is very high. And this is independent of the mismatch repair status. So this holds up for patients who have MSI high cancer, but it's also true for patients with microsatellite stable colon cancer. And it looks like there's about somewhere between 10 to 15% of patients with microsatellite stable colon cancer who have a tumor microenvironment that might be permissive of immune therapies. And so that particular population is a population that we're excited about advancing immunotherapies in the microsatellite stable group. And so that the versican and the breakdown of versican is a new biomarker that is going to be studied in multiple clinical trials moving forward. So next let's talk about advances in precision medicine. There was updated data presented at ASCO regarding the combination of cetuximab, vemurafenib, and irinotecan, specifically for BRAF mutant cancers. As many of you know, cetuximab is an anti-epidermal growth factor receptor antibody, and vemurafenib is a drug that targets specifically the BRAF protein. So on the surface of the cell, and many colorectal cancer cells have this, there's the epidermal growth factor receptor. And this receptor receives signals from the local environment and blood showing, or telling the cells to kind of grow, divide normally when nutrition is there. In the setting of BRAF mutations, this pathway or this signal that's telling the cell to grow, divide, gets turned on all the time. And we think that's a big reason why this particular type of colorectal cancer is actually a cancer, because it's constantly getting a signal for the cells to grow and divide and be cancer cells. And so there's been excitement about, can we actually use drugs that specifically block this mutated BRAF, and can we use that in combination with drugs that block upstream to completely shut down this pathway? And in some earlier data, this was shown to be beneficial also in the setting of chemotherapy. And so this clinical trial looked at patients with BRAF mutant colon cancer and compared cetuximab and irinotecan to the combination of vemurafenib, cetuximab, and irinotecan. Overall, the two regimens were fairly well tolerated, though the group that got the triplet regimen did have more trouble with keeping their white counts up. They had more neutropenia. There was also more nausea in the triple regimen. Excitingly, the progression-free survival, or the time to which it took the cancers to grow, was significantly improved in the triplet regimen compared to the doublet regimen. So the median change in progression-free survival, or the median progression-free survival, went from 2 months in the cetuximab and irinotecan group, so basically the time to the first CAT scan, to 4.3 months in the triple regimen. Now, this is a modest benefit, but it is a true benefit, especially for this BRAF mutant group, because in general, the BRAF mutant version of colon cancer tends to be the one that has the worst prognosis. And so if there are additional therapies that we can use that can help, especially this poor risk subtype of colon cancer, that's really important. So I'm excited about this regimen as potentially being a new standard option for patients with BRAF mutant colon cancer. Specifically, this regimen would be used in patients after they had progressed on the first-line treatments for colon cancer. And this is showing the response rates. With the triple regimen, the response rate was up to 16% versus only 4% for cetuximab and irinotecan. So next, let's talk about the adjuvant therapy and chemotherapy, the duration of chemotherapy, 3 versus 6 months. And so there is a international collaboration called the IDEA concept, where investigators from across the world have gotten together to try to figure out if we can save people the side effects of adjuvant chemotherapy by only giving 3 months of this chemo versus 6 months. And so this is kind of the general idea, looking at looking at patients with stage 3 colon cancer, randomizing to 3 months of chemotherapy versus what is typically thought of as the standard 6 months of chemotherapy. And these studies have accrued thousands of patients. I think the total accrual is over 12,000 now. And so this is a combination of 6 individual studies, all listed here from across the world. You can see there's patients from Italy and Europe, France, and then also the study that was primarily done in the U.S. Was the CALGB 80702 study. We enrolled many patients here on that study, and I'm really grateful for patients being willing to be randomized to shorter therapy from a standard regimen, so we can learn this valuable information. I think all of these patients who participate in this study have really helped advance the care for patients moving forward. What was found is, as anyone could guess, is that this FOLFOX and CAPOX regimens, so FOLFOX is infusion 5-FU, which is most commonly used in the US in this setting. CAPOX is using the pill form of 5-FU called capecitabine. That pill form is more commonly used in Europe in this setting. Mostly, I think, from a preference standpoint, but there is also, in general, more side effects with CAPOX than FOLFOX, and so FOLFOX tends to be more preferred here in the US. What was found specifically in this clinical trial is that when we only gave 3 months of these regimens, the rate of neuropathy or numbness in the hands and feet was much less. So in the 3-month arm, the rate of neuropathy was only a total of 17% versus nearly 50% in patients who have 6 months of this therapy. And so it is hopeful that we don't need to give as much oxaliplatin. If we give more oxaliplatin, clearly the patients have harm from that related to worsening neuropathy. And so in the primary analysis, they looked at the 3 months versus 6 months. And what they found is that at the 3-year time point, 74% or 74.6% of those patients treated with 3 months were doing well at that point without evidence of their cancer being back. In the 6-month arm, 75.5% of those patients were doing well without recurrence of their disease. And so a very elaborate statistical test was done to see if 3 months was as good as 6 months. And based on the robust statistical analysis, what was shown is that there's a chance that the 3-month regimen is not quite as good as the 6-month regimen, but they're pretty close. And so there's now been many different sub-analyses looking at patients who are lower risk versus patients who are higher risk. So we'll focus on these two panels here. Patients with what we call N1 disease, or a less number of lymph nodes involved, they had, in receiving FOLFOX, the difference was a little over 1.5% recurrence. Whereas if people had T4 tumors, so tumors growing into other things, or had multiple lymph nodes involved, then those seem to have a little bit more benefit from longer exposure to the chemotherapy. When we broke it down to CAPOX, so the capecitabine version of FOLFOX versus FOLFOX, it looked like maybe the CAPOX arm did just a little bit better. So we have to be careful when we're doing these subgroup analyses, because the original studies were not powered or designed to do these subgroups. And so these in general are quite exploratory. And when we think about the difference between CAPOX and FOLFOX, as part of this clinical trial, the patients weren't randomized to one or the other. The patients, doctors and the patients themselves were able to determine whether or not they wanted CAPOX versus FOLFOX. And since, in my opinion, CAPOX is a harder chemo to receive, in general, those patients would typically have to be in a little bit better shape to start with than the patients in the FOLFOX category. And so there may be some bias to capecitabine and CAPOX being better, because you have to be in better shape as a patient to tolerate CAPOX than FOLFOX. And so it might be that those patients were overall a better group of patients being able to be more active and more robust. And so I think all of these studies have left us and many oncologists with this question of, I don't know how to feel about the data. What we're seeing is that 3 months versus 6 months, in most cases, they're very, very similar. And we're talking about a small fraction of patients that might receive benefit from continuing from 3 months to 6 months of chemotherapy. Stopping early can clearly improve the quality of life for a larger number of patients by preventing the neuropathy that happens. And so there are many different ways in which oncologists are thinking about this data. So I have some colleagues who say 6 months of adjuvant chemotherapy should be given for everyone, because the studies did not meet their robust statistical endpoint that says 3 months is definitely as good as 6 months. Some people say, well, since the low-risk patients seem to do pretty well with 3 months, then maybe for low-risk patients or patients with T3N1 disease, we should do 3 months of chemo. And for patients with higher risk, specifically the patients who have a lot of lymph nodes involved, maybe for those patients, we should use 6 months of chemotherapy. Some other oncologists will say, well, maybe we should just continue the FOLFOX for 3 months, and then for the last 3 months, just do infusional 5-FU. That approach hasn't been studied, and so we don't know exactly what the benefit is to additional 5-FU. But my concern is if the benefit of the whole regimen is only 1 or 2% better, then odds are the benefit from less chemo is even less than 1 to 2%. And some people are also questioning about maybe we should use CAPOX more often than we use FOLFOX. However, I'm concerned about that, since this, as I said, this was not randomized between CAPOX and FOLFOX, and I think there is some inherent bias in the results of this, because patients in general who go on CAPOX have to have a better performance status than patients who go on FOLFOX. So overall, my approach to deciding the risk-benefit for patients is to actually take it on a very individual basis. So when a patient comes and talks to me about how long we should do adjuvant chemotherapy, I think we need to take into consideration their goals. I think we need to take into consideration their risk of the cancer coming back. And I think we also need to take into consideration how the patients do. So we have some people who do really well with oxaliplatin and only start to get neuropathy very late in the course. So if I have a low-risk patient who has absolutely no neuropathy, I think I would think about continuing chemotherapy beyond 3 months. Now, if I have a patient who's high risk and they're having bad neuropathy, even at the 3-month mark, then I think we need to talk about potentially stopping the oxaliplatin even at that point, because the harm that comes from additional oxaliplatin may be worse than the 1 or 2% improvement that we have with the oxaliplatin in preventing the cancer from coming back. And so I think it's going to need to be a very individual approach, but I do think it is exciting that in general, we can offer much less adjuvant chemotherapy than we thought we could before, meaning there will be many patients who will do very well with only 3 months of FOLFOX or CAPOX chemotherapy and not have to suffer the permanent neuropathy that many of us have had to deal with. So next, let's talk about survivorship care, and there's 2 major issues I want to talk about. One was a new study looking at tree nuts, which has received a lot of publicity lately, and then also the ever-present question of vitamin D. So there was a reanalysis of the CALGB 89803 study. This was a study that many years ago looked at whether or not adding irinotecan to 5-FU chemotherapy would be beneficial in the adjuvant setting. In that study, they also did a lot of banking of data related to diet and calorie intake and what patients were eating while they were on the study and after the study. And they had a specific question about whether or not tree nuts could help reduce the risk of colon cancer recurrence. And they looked at how many servings did patients eat of tree nuts, and how did that affect their outcome. And so when we're talking about tree nuts, we're talking about walnuts and almonds and pecans, those types of nuts. We're not actually talking about peanuts. I was not aware of this, but apparently peanuts are legumes, which is not and don't grow on trees, and apparently the growth on trees is important for colorectal cancer recurrence. What you can see here in these this lines on the graph is people who never ate tree nuts, they normalize their recurrence to 1, and then you can see a dose response. And the more people eat tree nuts, the less there was a chance that their cancer recurred, and more of a chance that they were surviving and doing great. And so in patients who ate at least 2 servings a week of tree nuts, there was a dramatic improvement in those patients' survival and the risk of their recurrence. And there's actually quite a bit of evidence looking in the preclinical literature about why this might be. However, I think every study had a different reason for why this might be the case, related to metabolism of fatty acid, related to growth of blood vessels. There's also some data on insulin resistance and how that could affect metabolism in cancer cells as well. So there is some rationale why this could be the case. Nonetheless, this is very exciting data saying that potentially supplement with tree nut and maybe tree nut related products that could reduce the risk of colon cancer. So next, let's talk about vitamin D and a study by Frank Sinecrope from Mayo. This is a study looking at levels of vitamin D in patients with stage 3 colon cancer. There's been a lot of questions about whether or not vitamin D levels matter for patients with colorectal cancer and whether or not we should supplement vitamin D for patients with colorectal cancer. And there's been a lot of mixed results across preclinical models in addition to in clinical trials. This particular clinical trial looking at patients in the stage 3 setting divided up the groups based on the lowest and highest tertile of vitamin D levels, and actually found that patients with the highest vitamin D levels did worse. And so that was somewhat unexpected, but does point that potentially strategies to provide supratherapeutic vitamin D are not necessarily good, because there are some people who are promoting very high levels of vitamin D supplementation, which at least at this point there's no data to indicate that that's a good thing. And so these studies were reviewed by Steve Cohen, and he presented his overall thought on things that have been shown to be beneficial or not in the setting of survivors of colon cancer, showing that physical activity has been shown to reduce the risk of cancer recurrence. Westernized diets have been shown to be harmful. Multivitamin use and statin use are kind of equivocal to their benefit in this setting. Studies of low glycemic index have shown that people who eat a high glycemic load, so diets that are very high in simple sugars, especially in patients who are already overweight, those patients have a much higher risk of cancer recurrence. There is data on actually coffee intake, and so more than at least 4 cups a day of coffee has actually been shown to be protective from colon cancer recurrence. I was really excited when I learned that, given my 5 cups a day baseline coffee intake. Not slowing down on that anytime soon. And now we have new data related for tree nuts, which is also something exciting to add to things to consider to help reduce the risk of colon cancer recurrence. And so what do I do, or what do I tell my patients, or what do at least I try to do? So after I meet someone who has gone now through their chemotherapy, I don't think necessarily doing all of these things while undergoing adjuvant chemotherapy is a good thing. But after adjuvant chemotherapy, I talk to patients about taking aspirin, so at least 81 to 325 milligrams per day. We talk about exercise, half hour of moderate exercise, more days than not. By moderate exercise, I mean doing some sort of physical activity. Now, it doesn't matter what that physical activity is at all, but at the end of that activity, you should be a little bit sweaty. You should be a little bit short of breath, thinking that, boy, you did something there. Now, not out of breath where you can't talk, but at least think that you've done some real exercise. I do talk to patients about multivitamin. The main reason for the multivitamin is calcium and vitamin D. The calcium, in my opinion, has some good data that it can reduce the risk of colon cancer. That got a lot of press here in Wisconsin as the dairy state. That data is from a couple of years ago. And then I think there's still a lot of question about vitamin D. There's been some studies showing that there's benefit to supplementation of vitamin D. Some studies showing that there's worse outcomes in patients with lower vitamin D, but then also now in this study that I presented here, in this cohort, actually, the patients with the higher vitamin D levels ended up doing a little bit worse. And so I think clearly high dose vitamin D supplementation, at least in the adjuvant setting at this time, doesn't make sense. But I do think trying to maintain near normal vitamin D levels with low supplementation is a reasonable thing to consider. Next, low glycemic index diet. So what we think is actually going on here is that that spikes in the blood sugar are bad for colorectal cancer recurrence. And so in general, when people are eating carbohydrates, we recommend complex carbohydrates, so multigrain, whole wheat type products. Those products in general are harder for your body to absorb. And so you don't get the same spike in your blood sugar after eating those as you do for simple sugars or like dessert type sugars or high fructose corn syrup. Those are also the reason why those foods don't necessarily taste as good. But like with anything, when you put your mind to it, those types of things can, you get used to it over time. Coffee has been shown to have a benefit. So I don't necessarily recommend that every person go out and start drinking at least 4 cups of coffee a day. But those people who do like coffee, there's clearly no reason to quit drinking coffee because of the risk of cancer. So there were some people who had been concerned about whether or not drinking large amounts of coffee would be a bad thing. And at least from what we know in the setting of colorectal cancer, it appears to be that drinking coffee is actually helpful. And then now tree nuts has significant data to show benefit. And so in general, in people who are willing to eat tree nuts, we recommend 2 handfuls per week of tree nuts as a dose that seemed to be beneficial in the study. For those patients with ostomies or histories of diverticulitis in which nuts can be particularly troubling, I think there's at least hope that things like almond milk or almond butter might be substitute products that would have some beneficial. But one caveat to that is that we have no data related to those tree nut products and whether or not they have the same benefits as the actual nuts themselves. One final thing that I didn't put in on the slides, but I do want to make sure I mention, is that there was one additional study that looked at whether or not we should be using PET CT scans. So PET CT scans look at the metabolism of either cancers or other parts of the body to help potentially identify things sooner. And so there was a question of whether or not we should be using PET CT scans as opposed to regular contrast CT scans after someone's been diagnosed with colon cancer for surveillance. And it was actually shown that regular CT scans are better than PET CT scans for patients. And so that's a big relief that what we've been doing with regular CT scans is important moving forward. So I think I'll turn things back over to Sharon and happy to answer any questions.
Thanks, Dusty. Let me just change over the slides really quickly. Okay, so we did have a number of questions come through for Dr. Deming, and those of you who are tuning in and listening live, again, a reminder, at the bottom right-hand side of your screen in the control panel is a question area, and you can type in your question there and it'll get directed to me so I can ask Dr. Deming. So we'll go ahead and get started. So specifically the CEA TCV trial, what phase trial was it? And do you know, were there any other studies presented at ASCO that were targeting MSS patients specifically?
So this was a phase 1 clinical trial. So this clinical trial is still looking at, what's the right dose and how should we give this particular drug. But with the amount of activity that we were seeing specifically for the MSS population, of the things that we have right now, the MEK inhibitor plus anti-PD-L1 and now this CEA antibody are the two things that have shown the most promise, specifically for the microsatellite stable group in the immunotherapy setting.
Okay, great, thanks. Our next question. The study that details the 3 or 6 months adjuvant chemotherapy, the results you discussed were for colon cancer patients. However, do the results also cross over to rectal cancer patients as well?
So only one of those 6 patients have, or one of those 6 studies that were included in that collaboration included patients with rectal cancer. So in general, and it didn't include any patients who had chemotherapy before getting radiation. And so in general, our thoughts have been that we should do chemoradiation and at least 4 months of FOLFOX for patients with locally advanced rectal cancer. And so at this point, there's not additional data specific to rectal cancer to say that that should be different. And when we're thinking about for rectal cancer patients, looking at these data, 4 months might be right about where we should be.
Mm-hmm. Okay. So we have, this is a hot question. I see it from a number of people. Is decaf coffee as beneficial as caffeinated coffee?
So unfortunately not. So in the study that looked at coffee, they looked specifically at caffeinated sodas, which were not beneficial, and decaf coffee, and those were also not beneficial. It was the regular coffee that seemed to reduce the risk.
Okay. So if you're trying to avoid the caffeine, it has, they were looking at caffeinated beverages only. All right, so our next question is about the tree nut study. Did the patients report their tree nut consumption real time, or was it retrospective? In addition, were there any other health factors taken into account for this study, for example, exercise behavior?
That's a very, very good question. So one of the benefits of this particular study is that the diet questionnaires were filled out prospectively, meaning at the time the patients were undergoing the study, it was not done retrospectively. It was retrospectively analyzed, meaning they went back to it after the fact. But all the diet logs and things were filled out in real time. And they did control for a number of factors during this analysis, including physical activity and many of the other commonly thought of things that can affect prognosis in this setting. So the investigators did a great job as much as possible trying to control for this outcome.
Great. Okay, our next question. And this question is directed at you, Dr. Deming. As a former patient yourself, would it be more difficult for you to recommend a triplet version of a new therapy versus a double regimen if the benefit is modest and the cost to the patient will quickly add up?
So I think it's very important that whenever we're thinking about a therapy, regardless of how many drugs are involved, I think it's important that we understand what is the overall benefit of that regimen for that particular patient, meaning how long is it going to prolong their life, what are the odds that that particular combination is going to shrink their cancer or alleviate any symptoms that they may have at that point. And then we also have to weigh in what is the financial burden and that will come with that regimen. What is the amount of infusion time or visits to the hospital that patients will have to do because of that regimen? And then also, what are the other toxicities that come along? And so I think anytime we're thinking about a therapy, whether it be a doublet regimen or a triplet regimen, we need to think about what are the overall toxicities across many different aspects, and what are the potential benefits.
Great,
and I
that's
think
a good answer.
being as honest as you can with patients is important, because none of us can make the decisions about what we want unless we really know what's going on.
Absolutely, that's a great discussion and great answer about making sure that your values are discussed with your doctor and shared decision making takes place with all the treatment options, treatment decisions. Our next question. Oh, this is a similar question to previously, but focused on the TreeNut study. Was this only for colon cancer patients, or does it cross over to rectal cancer patients as well?
So this particular study was specific to patients with stage 3 colon cancer. Now, that being said, I would envision that these results would also be able to be, myself as a rectal cancer survivor, I'm looking at these results as they matter to me as well. There hasn't been and probably won't be a specific rectal cancer analysis of this, because I'm not aware that this data has been collected on a clinical trial specifically for rectal cancer. But I think the risk of eating more almonds is pretty low, and so at least in my own opinion, think it makes sense to apply this for colon and rectal cancer patients.
Thank you. We have just a couple more questions here. So this is in reference to the adjuvant chemotherapy study. Are there any additional studies that you know of that are targeting side effects like neuropathy aside from this study?
I am not aware of specific studies that are looking at ways in which to reduce side effects. I think the studies that I'm aware of is there's a new study coming to look at patients who have mismatch repair deficient cancers, and would immune therapies help in the adjuvant setting. And then there's a lot of work that's going on looking at what would be ways in which we can enhance the way in which patients can follow a lot of the survivorship guidelines related to exercise and low glycemic index diets and things like that. There's a lot of work, whether it be with smartphone apps, Fitbits, etc., strategies to help patients follow some of these guidelines. I think that's where a lot of the work's being done right now. I'm not specifically aware of other studies looking at how we reduce risks in the adjuvant setting.
Okay. What do you consider a safe dosage of daily vitamin D?
Of daily vitamin C?
D.
Oh, vitamin D.
Yes.
So in general, it was good because I didn't know the dose of vitamin C off the top of my head. So for vitamin D in general, what I recommend is multivitamins, which in general have either 400 or 800 international units a day.
Okay.
And that's opposed to some studies that are, or some groups that are recommending, 8,000 or 12,000 international units a day.
All right, so we have about 2 more questions here. And I believe this is in reference to the discussion about the glycemic index. So the question asks about stevia safer than table sugar. So I guess more broadly, does it matter if it's table sugar versus, sugar alternatives like stevia, for example, or honey or other types of sugar substitute?
Yeah. So I think the honest answer is the sugar substitutes have not been, at least in my opinion, well studied in this setting, and so we don't necessarily know the impact of sugar substitutes. What we do know is fruit-based sugars don't seem to be as big of a problem, because we know that diets that are high in plant products, fruits, and vegetables, those tend to also be good for reducing the risk of colorectal cancer recurrence. So in general, I talk to patients about trying to reduce their intake of simple sugars, dessert type sugars, high fructose corn syrup as a place to start. But
Okay.
I do think like fruit-based products may be a better alternative.
Great. Our last question for the day, were there any new studies in the treatment of KRAS mutated, so non-wild type KRAS metastatic colorectal cancer? And what's looking ahead in terms of future treatment options for this particular biomarker?
So that's a really active area of research. There are a number of studies that are looking at potential options for patients with KRAS mutant colon cancer. The studies that are farthest along are the ones that look at the MEK inhibitor, cobimetinib, with the anti-PD-L1 antibody atezolizumab. A recent phase 3 clinical trial comparing that regimen to regorafenib has completed enrollment, and we're waiting for those results to come out. I haven't heard exactly when they're coming, but I would be hopeful that maybe by ASCO next year we might know more about that particular regimen and whether that's beneficial for patients with those particular mutations. Other than that, there's some studies that have shown a little bit of excitement, but we still have a long way to go for that particular type of colon cancer.
Okay. Well, thank you so much, Dr. Deming, for taking time out of your day to give us all this great recap on ASCO 2017. And thank you to all the folks that tuned in live. And again, this will be posted to our archives, so you feel free to check it out again later. And again, thank you so much, Dr. Deming, and have a wonderful rest of your day.
Thank you so much. I really appreciate the invitation to give this talk, and everyone for joining us today.
All right. Bye, everyone.